Hi, and welcome to this lecture on a healthcare system in New Zealand. So this is what we will cover in this session. So starting with introductions, my name is Agnes Arnold. I am an anaesthetic technician in Rotorua, New Zealand. This is my education background that you can see on the right here. I have been a registered nurse specializing in perioperative practice, so operating theatres, but predominantly anaesthetics for over 20 years in several countries. So this is what my usual job looks like. It involves a lot of clinical work. It involves a lot of equipment checking and equipment maintenance, but it predominantly involves helping anaesthetists in a clinical setting. But there is also some non-clinical components such as teaching, etc. So there's also a lot of nighttime work. Including call out for emergencies, etc. And so hence the coffee and chips over here, which help me to get through the night if we're there for a while. I've been lucky enough to work in a couple of other countries as well for short periods of time. But enough about me, we need to move on to the New Zealand healthcare system. We're going to look at it through the lens of the World Health Organization. So WHO Constitution envisages health as a human right of all human beings. To achieve that right, all countries need to strive towards universal health care. Universal health coverage, according to WHO definition, means that all people have fair access to health services they need where and when they need them without financial hardship. Why is it important? Well, here we've got a few key background facts that WHO present about the world. So half of the world's population do not have access to healthcare they require, and 100 million people are driven into poverty each year through healthcare spending. So, this is a huge humanitarian issue, which each country needs to address in their own countries. And so where does New Zealand fit into all this? So New Zealand is a small island in the South Pacific. We have a population of 5 million, which isn't very big, and a fairly large area. And so the population density is quite low. There's only 130 public hospitals, only a handful of doctors, a handful of nurses, and literally a handful of ICU beds. So with the population spread out so far and wide, and just a few medical centers available, it causes some geographical issues for access. And we'll be looking at the barriers to access to healthcare in New Zealand a little bit more detail later. I'd like to point out the ethnic groups as well. About 30% of the population are comprised of various ethnic minorities, with the majority being the white European population. All New Zealand citizens and residents, and some work visa holders as well, have access to healthcare that is either free or low cost. So that's in principle, at least. We'll see how that works out in practice in a minute. How is that universal health access achieved? Well, it looks quite complicated on this diagram here. But we're not going to look at every aspect of it, just a few main areas. So we've got the we can point out that the central government and the Ministry of Health run the entire of the healthcare and disability sector in New Zealand. But there is a couple of other areas that I want to focus on in a bit more detail, which are specific to New Zealand healthcare system, and that's the District Health Board, which, as you see, is financed directly through taxes by the Ministry of Health. And we're also later going to look at the ACC Accident Compensation Corporation system in a minute as well. Let's look at the district health boards. So New Zealand is divided into 20 areas, 20 districts, and each one has got its own health board, which manages, funds, and runs all public hospitals in New Zealand. So moving back to a slide here, district health boards get money from Ministry of Health from taxes and provide all of the, all of the tertiary and secondary services, hospital level, for free for everyone. There is DHBs also come into agreement providing partial funding with private providers to arrange community care. So here we go, they've got private and non-government organizational providers, and they include pharmacists, they include your general practitioners, and they include majority of community services. Now, these are not fully funded by the DHB. They are only partially funded through service agreements. And so to meet the operational costs, these providers in the community require some co-payments from the public. Why is that important? Well, it is because community level care is your primary care, your first level care. Let's look at general practitioners. Now, the institution of a general practitioner in New Zealand is very important. You really cannot, as your family doctor, your coordinator of your entire care, you cannot access any other service without, apart from emergency services in the emergency department and hospital, you cannot access any other service without a referral from your GP. And so seeing your GP is, you know, incredibly important. And most people see them, you know, quite frequently. And because of the system in which, you know, these organizations only get a small portion of their costs met by the government and require co-payments by the public, you know, we see that there is a GP consultation charges for just 15 minutes are actually quite high, vary greatly from area to area, but in some areas are actually quite high. We also see that ambulance is not fully funded either. In actual fact, ambulance are a charity in New Zealand, and they fundraise for their own operational costs, but they can never get enough money for fundraising. So they need to charge for each and every transport that they provide. And so citizens will pay about $98 for an ambulance call out, but foreign nationals may be paying $800 and more. There's also medication charges. Again, these are subsidized, but not free. So even the fully subsidized medication will still incur a $5 charge per prescription, and some unsubsidized medications are quite expensive. There are some safety nets built into the system for people who cannot meet those costs or who might struggle to meet their costs. So children and youth under age of 14 have got free healthcare and free medication, but there is some other groups as well that might suffer from low income, such as elderly and people who haven't got jobs, and they might have some ways of accessing reduced, reduced co-payments. So they may be getting some additional subsidies. And there's also cap on how much you can pay per year on medication. However, these are, there's still people who fall through the cracks to access some of these subsidies. you may, need to jump through several administrative hoops, and yes, so some people may still fall through the cracks and not be able to access those. So how does it all split up? I'm sorry, these are slightly dated figures, but as far as I'm aware, those percentages haven't changed that much recently. So we have got publicly funded services, which is your 83%. But if you look at privately funded, 20% is still a reasonable amount of private funding. And of that, 10% of the entire healthcare funding in New Zealand comes from out-of-pocket payments by individuals. And let's just look at the ambulance as well. They also are needing to fundraise for their costs. So that's quite an interesting system. So we can beginning to see, we're looking at these percentages that cost could be quite a significant barrier to healthcare in New Zealand for some people, especially if they do fall through the cracks in those safety nets. So socioeconomic status is a big driver of that. With Maori and Pacific Islanders more likely to suffer deprivation and poverty in New Zealand than non-Maori, non-Pacific citizens. We've got geographical barriers. We've already discussed it. We've only got a handful of hospitals, a handful of doctors. We need to, some people might have transport issues to, some areas might not have a GP. You might have to travel a long way to get to one. Some areas don't have telephone and internet access, so that causes additional issues for access for those people. And we saw how many ethnic minorities we have in New Zealand as well. And so language could be quite a significant barrier for quite a substantial proportion of the population. There's educational barriers, there's cultural barriers, there is institutional barriers, there's societal barriers, political barriers, historic barriers. So there is actually quite a complex issues here. So inequalities in health in New Zealand are a problem due to those barriers. Those are the reduced levels of health are predominantly experienced by the Maori and Pacific peoples. And if we look, for instance, as an example of life expectancy, there's huge variation based on gender, based on ethnicity, but also, on the deprivation index, with this side being the richest people, this side being the poorest. There's quite a big difference between rich and poor. But if we look, at the same deprivation level, European females and Maori males, there's a huge gap of about 20 years in life expectancy. These are quite serious issues that the country is trying to address. And we see over the years, the gap in between, for instance, cardiovascular disease mortality rates between Maori and non-Maori is narrowing. So there is being a lot of work done to try and to reduce this inequality, but they certainly still exist. I want to look back now at our chart of the healthcare system and look at so we've pretty much covered this part of it. The Ministry of Health pay for the DHBs and they provide care for the population. But there's a separate avenue as well, which is a major contributor to healthcare spending, but is quite an interesting aspect of New Zealand healthcare system. And so that's why I want to address it. So that's the ACC system, or Accident Corporation. And they are also called Social Security. It's essentially an insurance scheme. And they provide, not a vast amount, but a reasonable amount of the healthcare funding. Excuse me. So ACC, it's a government insurance, a social security. It's funded by taxes, by employer and individual levies, but mainly through investment shares and dividends income, like most other insurance companies do everywhere in the world. So ACC provides funding for emergency and ongoing healthcare and income support for all accidents and injuries sustained in New Zealand. So not just for citizens, like the other publicly funded services, but for everyone. However, it will not cover disease from any other causes, so it's literally just accidents and injuries. Excuse me. To make a claim, and that's the bit that makes it, stand out, and an interesting aspect that's quite different to a lot of the other systems, healthcare systems where I've worked. It's a no-fault scheme, so you don't have to prove, the patient does not have to prove that someone else was at fault. This creates quite an interesting scheme. And an interesting situation, and that when the scheme was introduced in the 70s, it essentially took away the right to sue in the courts for injuries and accidents that are covered by it. And because all medical treatment injuries are covered by ACC, it essentially barred medical malpractice litigation in New Zealand. So it's a true no-fault healthcare system. And that's, quite a unique situation. So does this benefit patients? Yes, it benefits patients because compared with medical malpractice systems, such as, for example, in the US or in many European countries, the ACC system offers more timely compensation to a greater number of patients because they don't need to apply for they don't need to look for lawyers, they don't need to go to court, they don't need to suffer through lengthy legal costs and lengthy legal proceedings. They don't need to prove that anyone else was at fault. They can just fill in a form and get compensation. It really simplifies the complaints procedure for the patient. Does it benefit staff? Well, I don't think it really changes a lot for the staff, because staff are still responsible to the courts. You might not be liable for litigation, but you might still have criminal charges brought against you through particularly blatant or negligent behavior, or you've still got professional body tribunals, you've still got employment and disciplinary procedures. So yes, I guess it does take some pressure off the staff, knowing that they can't be sued constantly for every tiniest thing. But on the flip side of that, it doesn't really take all the pressure off. We're still there, we're still liable, we're still responsible to the patients and to our employers and to our professional bodies which govern our respective professions. So I just thought I'd mention that because it was quite an interesting aspect of New Zealand healthcare that I hadn't met anywhere else. So how is New Zealand doing in achieving universal health coverage in the light of what we've heard so far? Well, there is two markers of universal healthcare according to WHO. A population that can access essential quality health services. Well, at least in principle, every New Zealand citizen can. We've seen there are some barriers, we've seen there are some inequalities, but overall, in principle and by and large, most people can and do access quality health services when they need them. Proportion of the population that spends a large amount of household income on health. Again, there are costs, but there are also safety nets to protect people from those costs who can't meet them. And yes, some people still fall through the cracks, and yes, there's still some way to go. But we also see that WHO clarifies that universal health coverage does not mean free access to every possible health service for every person, because resources are limited. No country would be able to provide everything free for everyone all of the time. And so every country has got a different path to achieving it. And so how does New Zealand path look against all the other countries? Well, New Zealand, according to WHO, ranks 41 out of 191 countries that they've ranked when it comes to health coverage. So we're probably not doing too badly, although there's definitely room for improvement. And according to Commonwealth Health Fund, New Zealand has achieved universal health coverage for a mostly publicly funded, regionally administered delivery system, which, like I said, is not perfect, but you know, it's a work in progress, and we're striving towards improving it all the time. If you want any more information on in-depth recap of New Zealand healthcare system, and you only have time to read one thing, this link is really good. They do a nice overview of the whole thing. So that's enough about that, and just a quick look at New Zealand medical training, because that might be of interest to you guys. So essentially, how do you become a doctor in New Zealand? Well, there's two universities. You can see them here. There's University of Dunedin and Auckland that provide a medical degree training. The full title is this, it's quite a mouthful. 6 years full time, 19-year-old onwards after secondary school. Primary and secondary education in New Zealand is free, but university is not. So New Zealand medical students will pay a fair amount of money, between 7,000 and 16,000 New Zealand dollars per year. Overseas students are not subsidized, so they will pay more, substantially more. These are just tuition fees alone. You know, this doesn't cover the travel, the equipment, the accommodation, the food that they will, you know, they spend during their training. So there's 6 years full-time training. You know, some of those people can accumulate quite a substantial student debt. Assessments of the medical training are a mixture. So overall, New Zealand's moving away from the traditional exams, you know, the summative assessments, but it tries to move towards formative assessments, which is an ongoing assessment, feedback, essays, assignments, projects, and the New Zealand medical training has got a combination of the two. So here is an example of program structure from Dunedin. Auckland's a little different, but the principles are similar. So year 1 is basically just health sciences foundation. Year 2 and 3, early learning and medicine. And that's predominantly formal teaching and independent learning. Years 4 and 5 are advanced learning and medicine, and that's predominantly clinical, but there is some lectures as well. Years 1 to 4 are predominantly formative assessment, but year 5 has a big formal exam, so you do have your summative assessment coming in there as well. Year 6 is predominantly consolidation year in a clinical setting. So once they achieve their degree and become a Bachelor of Medicine and Bachelor of Surgery, what happens then? So career progression is not automatic. There's an open job market, and so at every step, those doctors need to apply for a job, go for an interview, provide references, and they do or do not get the job that they're after. So it's quite an interesting system that can make the training last quite a little longer for some people who haven't managed, for whatever reason, to secure the jobs that they were interested in a timely manner. So the first 2 years are as a house officer, just rotating for areas every 6 months, so they're very much still just consolidating and learning still. Then the house officer apply for trainee registrar position, and so registrar is your job. It's the start of your specialist training in your desired discipline of medicine. So you could be a registrar, orthopedic registrar, you know, anesthetic registrar. Registrars complete between 3 or 6 years of training as a registrar, depending on what specialty they're training for. So there'll be so there'll be 3 years for, say, a GP, and 6 years plus for surgery, anesthetics, etc. In that time, the registrars also undertake exams, a master's degree study, etc. So it's quite a full-on time for them. Once all the training is complete, all the exams are passed, and they've completed their registrar training, they can start applying for consultant or specialist jobs. And once they are a consultant, they can commence private practice as well. Up until then, all this training is all in public sector. So it's a lengthy training time. If everything goes your way and you're only in a discipline, for instance, a GP that doesn't require a lengthy registrar training, you might take 11 years from the moment you entered medical school to becoming a GP. If you want to be a surgeon or a heart or brain surgeon, that is a very specialized area, it will take you 15 plus years to achieve your consultant position. So this is a very long training time. Remuneration or pay, trainee junior doctors, that it doesn't look too bad, but they do have a huge student loan, to pay back. So yeah, not the best pay probably, but once they become a specialist or a GP, things start looking out for them. They get in between 115 to 112 in the public healthcare. Once they're a consultant or a GP, they can also start private practice. And so that will allow them to earn a little more than in the public. And that's all from me. Thank you very much.